everyone, and welcome to today's lecture, Medical Records and Documentation. From this lecture, we will learn the following things: the importance of patient medical records, the documents that constitute a patient medical record, SOMR, POMR, SOAP, and Cheddar medical record formats, the 6 C's of charting, giving an example of each, the need for neatness, timeliness, accuracy, and professional tone in patient records, the correct procedure for correcting and updating a medical record, and the steps in responding to a written request for release of medical records. Let's get started. The importance of medical records. Patient record or chart. A patient record is the repository of information about a single patient. This information is generated by healthcare professionals as a direct result of interaction with the patient or with individuals who have personal knowledge of the patient. A patient record chart contains the medical history and present condition of the patient. Legal guidelines. Under Respondent Superior, the physician is held responsible for the action of a medical assistant who may be entering documentation in the patient's chart. The need for accuracy is very important, as mistakes could jeopardize the patient's health and the physician's reputation. The saying, "If it was not documented, it was not done," is well known and used to emphasize the importance of documentation. For patients who are non-compliant, documentation of medical advice is used to verify instructions which were given. Standards for records. Records should be complete, accurate, and well documented. All records are physician's responsibility. Patient education. Information can be gathered from individual patient records and aggregated into data involving healthcare outcomes. Test results can be tracked from patient records and to study uncommon conditions. Quality of care. Audits used for care analysis can be done through patient records, and they can be used as a basis for future policies or plans. Research. Patient records can be used for researches on patient responses, behaviors, symptoms, side effects, and outcomes. Research can provide answers to improve quality of care and to present answers for emerging trends. Contents of patient medical records. Patient registration form. The patient registration form contains basic demographic information, and initial information is rechecked at each visit. Patient medical history. The patient's medical history sets the foundation for possible reasons for seeking medical care. Contributing factors such as poor diet and exercise habits, smoking, or the use of alcohol and drugs combined with other factors in the history could help the physician gain needed information to make an accurate diagnosis. The physician may contact the referral source for help in verifying the patient's history. The patient's medical history may include the following: illnesses and surgeries, allergies and current medications, family medical history, social and occupational history, and history of present illnesses and chief complaint. Physical examination form. Review of systems, ROS, contains inventory of status through a series of questions. A review of systems may help identify signs or symptoms and will help direct the physician when performing a patient's physical examination. A head-to-toe inventory is done in a methodical way, guided by subjective comments from the patient. The medical assistant most likely will document the patient's vital signs, temperature, pulse, blood pressure, and respiration, as well as height and weight for the chart. Physical exam verifies answer. Results of laboratory and other tests. Results of laboratory and other tests can be obtained through outside sources and their records on flow sheets, as they provide ease of tracking. Documents from other sources. Documents from other sources include authorization for release of information and records from other physicians and hospitals. Diagnosis and treatment plan. Assessment is determined after study of subjective and objective findings. Treatment plan can include different viable options. Operative reports, follow-up visits, and telephone calls. Operative reports, follow-up visits, and telephone calls span over procedures and surgeries. Progress notes and patient contacts are properly managed. All incoming information on the patient is gathered and organized into the chart. Hospital discharge summaries. Hospital discharge summaries include the following: reason for hospitalization, containing admission and discharge date and admitting and diagnosis, as well as history of illness, tests, procedures, and operations, medications, and outcomes including complications, patient follow-up instructions, and discharging physician's signature. The discharge summary is an important document in the patient medical record because it chronicles time spent in an acute care setting. All information gained can assist the treating physician to understand ongoing concerns. Consent forms. These must be signed and witnessed. Correspondence with or about patient. All correspondence should be marked or stamped with the date the medical office received the document. Correspondence can be done with other providers or laboratories. Information received by fax. Information may be received by fax when required rapidly. Requests should be made that an original of any fax documents be mailed to the office for the final record. Dating and initialing is needed before filing. Maintaining confidentiality for patients' rights. Patients must receive a written notice of privacy practices on their first visit to a healthcare provider. Only minimal amounts of patient information should be released to meet the current needs of the patient. A reasonable effort must be made to communicate with the patient in a confidential manner. Always follow protocol established by the Office for Medical Record Copying. Healthcare providers have the right to require a request to amend a record be made in writing. A written record of any request by the patient for information and the response of the healthcare provider must be maintained. Patients' rights include right to notice of privacy practices, right to limit or request restriction on PHI use and disclosure, right to confidential communications, right to inspect and obtain a copy of PHI, right to request an amendment to PHI, and right to know if PHI has been disclosed. Types of medical records. Source-oriented medical record, or SOMR. The SOMR is sometimes called the conventional method. It contains patient information arranged according to supplier of data, progress notes in reverse chronological order, and one section for each department sending information. This system can make tracking the progress of a specific problem confusing. Retrieval of information can be fragmented and require a lengthy search. Problem-oriented medical record, or POMR. In the POMR method, each problem is given a number and tracked accordingly through the chart. POMR includes database of history, physical, and tests, problem list, each problem is listed separately, signs are objective, external, and symptoms are subjective, internal, educational, diagnostic, treatment plan, and progress notes done in SOAP format. Subjective Objective Assessment Plan, or SOAP. The SOAP format is used with both SOMR and POMR charts. Physicians will often dictate a letter following the SOAP format, and paragraphs can be separated by SOAP categories. SOAP includes subjective data from the patient, start SOAP note, objective data from the physician, exams and tests, assessment diagnosis and impressions, and plan of action. It includes the following: treatment options, medications, tests ordered, consultations, patient education follow-up. Cheddar format breaks SOAP down into C, chief complaint. The chief complaint is the problem the patient subjectively describes as the reason they are seeking care. H, which is history. History will consist of past medical, family, and social history. E, examination. D, details of problem. D, drugs and dosage. And A, assessment. And lastly, R, return visit or referral. Documentation and the 6 C's of charting. Documentation includes the following: updating medical forms. Updating medical forms. Medical forms need updating when patients move, marry, have children, or change insurance. The medical record is updated each time an X-ray or lab test is done or a letter arrives from a specialist. Documenting test results. The office medical assistant will record vital signs, current medications, and ask about responses to treatment as they prepare the patient for the examination. Examination, preparation, and vital signs. And lastly, follow-up. Follow-up may include transcription of notes, posting lab or examination results in the medical record, or noting telephone calls made. Medical or discharge instructions given to the patient will be recorded, and the physician may also request the medical assistant to counsel or educate the patient regarding home care. The 6 C's of charting are client's words. Be sure to record the patient's exact words rather than rephrase for proper grammar. Clarity. Use precise descriptions and accepted medical terminology when describing a patient's condition. Completeness. Fill out forms used in the patient record completely. Conciseness. Be brief and to the point. Be careful with abbreviations. Chronological order. Be sure all entries in the patient record are dated. And lastly, confidentiality. Information in patient records and forms is confidential. Appearance, timeliness, and accuracy of records. Neatness and legibility. Medical transcription means transforming spoken words into written notes. Handwritten notes are written in blue ink. Make sure all handwriting is legible. Timeliness. To ensure timeliness, record all exam and test results as soon as available. Accuracy. Accuracy guidelines require the medical assistant to check all information carefully and to verify any information when there is doubt or question on an item. Professional attitude and tone. Never record personal, subjective comments, judgments, opinions, or speculations about a patient's words, problems, or test results. Correcting and updating medical records. For written records, the correction is usually done by carefully drawing a single line through the error and then writing the correction information just above the line. Mistakes are not uncommon and always make corrections according to office policy. The date and reason should be noted along with initials of the person making the correction. Having another staff member witness and initial the correction is a good safeguard. For the electronic record, corrections are noted automatically in an audit trial. Updating patient records must follow established protocol. The medical assistant may be called upon to witness the updating of a patient record, responding to release of records requests. Procedures in releasing records include obtaining signed and dated release, getting photocopies of requested materials, and calling recipient to confirm materials received. Confidentiality. Special cases, if in doubt, check with supervisor and protect each patient's right to privacy. To release any confidential medical information, express written permission from the patient must be received. The copies should be made and the originals should remain in the medical office. Only records expressly requested and authorized by the patient should be released. Auditing medical records. Internal audit. In internal audit, random charts are done by staff. Prospective internal audit is done before billing. Retrospective internal audit is done after billing. External audit. External audit is done by government entities like Medicare or Medicaid and is managed by care organizations and private carriers. The internal audit schedule is determined by the medical office, while the external audit will be done according to the federal program or private payer's timetable. If an error is found on the external audit, overpayments will be returned to the payer, and a penalty may also be assessed. Penalties range from loss of ability to participate in federal programs to jail or loss of the physician's medical license. That concludes today's lesson.